Good afternoon. Welcome to the public board meeting of Lancashire and South Cumbria ICB. As always, I'd like to start by thanking those members of the public who are observing this board, either in the room or through the live stream. I would also like to welcome Neil Jack to his first board meeting as partner member for the local authorities, and Alex Heritage to his first public board meeting as Chief Strategy and Planning Officer. Gosh, Alex, it doesn't feel like this is your first public board meeting. And I would also like to welcome Dr. Santosh Davis, who is the Clinical Care and Professional Lead for Lancashire and East Lancashire Place-Based Partnership. Santosh is here just observing as part of his own professional development. So, apologies and introductions. I've got apologies from Andy Curran, Julie Colclough, Kath Wally, Chris Oliver and Craig Harris. Thank you to Jane Cass, who is deputising for Craig in his absence, and who will present agenda item 14, which is the case for change, the integrated urgent care redesign. The meeting is quorate, and as always, it's good to maximise discussion time. So I'd ask that executives keep introductions brief and in the light of context. We've all read the papers and we've all digested them, but a little bit of context is always good. Declarations of interest. So I haven't received any declarations in respect of today's agenda. Are there any? No. So obviously if that changes as the meeting progresses, please do let me know. So, moving on to the agenda then. First of all, minutes for approval as an accurate record of the last meeting. That was on the 14th of May, 2026. Are there any comments on accuracy? No, so we're happy to formalise those. Then the... there was one small typo on page 11, reference to the Office of Public Inquiry Commissioning. This should be the Office of Pan ICB Commissioning. So we've amended that. The action log. Currently no actions on the public board action log. There's nothing that we've missed, is there, from the minutes, I think? No, good. So we now move to how we start all of our public board meetings, which is our community experience story. Today, this is improving access to blood testing for patients with learning disabilities or severe needle phobia. Delighted to welcome Dr. Karen Perkins, and I'd like to ask Andy just to introduce it.
Thank you, Chair. Good afternoon, everyone. So we're going to look together at a beautiful piece of work around something called touch-activated phlebotomy, which has won national awards and has been featured on the BBC as a really stunning piece of work. Really grateful for Dr. Karen Perkins for her extraordinary leadership in this work as lead clinical scientist at UHMBT, and also the work that she's done alongside one of our ICB clinical lead previously for learning disabilities and autism, Dr. Julia Smith, who's a GP in the Carnforth and Milnthorpe PCN. It's a really lovely story and demonstrates things that we passionately care about together as a board. One is tackling health inequity and improving outcomes for those who need it most. Secondly, real innovation and learning to work differently. Thirdly, working collaboratively between our different partner organisations. And then fourthly, learning how we codify really great work and see how we scale and spread it more widely across the system. So Karen, welcome. We're so grateful that you're with us and we look forward to the piece. Thanks.
Thanks very much. Thanks. That button? I thought I'm loud enough anyway. Thanks for inviting me. It feels a little bit like Dragon's Den here, so I'm like hoping someone's going to come with a big stack of cash at the end of it for me. But I brought some toys for you to play with. So before we start, if I put those two there, and I'll put these two here, the device that we've used is touch-activated phlebotomy, so it's the one with the blue plunger, but I'll explain the others as I go. So if you want to have a little look, and I'll explain as we go round. So the story begins with us as clinical scientists sat in blood sciences at Morecambe Bay at this stage. with GPs and learning disability nurses phoning us saying we have a patient that we just cannot get a blood sample from, we can't get near them with a needle, they need testing, they're on medication, they need some kind of annual health check, we can't do it, what can you do? And in the best case scenario, we can use a dried blood spot card, which is what you do the heel prick for on neonatal patients, to do the neonatal screening with, and we can do a TSH, a thyroid hormone, on that, and that's it at this stage. So myself and Andrew Brown, who's our consultant clinical scientist, we were just playing around on the internet, as you do, you get down a rabbit hole, and we discovered transdermal capillary sampling devices, which is what I've just handed around to you. So these are devices that stick on your upper arm after you warm it up, and they pierce your skin very, very gently, kind of like a finger prick, but because it's on your upper arm, you have very few nerve endings there, and it's relatively painless. The TAP device is extremely painless, and we have some excellent feedback from our patients that we're using this in as well. So suddenly, we're able to access blood from these patients who have to have general anaesthetic, months and months of desensitisation work, no blood sample at all, and you're guessing what you're dosing them with, or are they developing diabetes, heart disease, all sorts of long-term disorders now. There's a 20-year age gap between patients with learning disabilities. The mortality age gap is 20 years. You all know that, teaching to the people who know more, probably more than I do as a clinical scientist. But we found something that we can access blood tests with. 60 to 70% of clinical decisions involve a simple blood test. A simple blood test for most people, but for these patients it's not. So I put a couple of slides together. I don't know if you can all see them. So this project is about taking the conventional system of a venipuncture with a big blood volume and using a microsample volume. This involves lots of changes within our laboratory, a different process, and I kind of, that's my Dragon's Den bit, the support bit that we need in the laboratory. But the benefits it delivers for all sorts of different patient groups is phenomenal. So delivering hospital to community is part of the 10-year plan. Blood sciences could very much be strategic health partnership in moving this, but we need to be integrated into those processes for those discussions. We're not just about testing providers. We have innovation within our laboratories, and there are things on the market that we can bring in now as well. So maybe the next slide there. This just outlines where we are at the moment. So we have just formed Lancashire South Cumbria Pathology Network, and we're all one big happy family across 4 trusts, but we have 4 different analytical platforms within there, so we've got technology differences. Within scope is the laboratory, the IT, and getting the results out to the requesting clinicians or the patients. But what's not in scope there is how the tests are requested, where is the blood collected, and how is the blood collected, and how does it get to the laboratory. So the whole beginning of our supply chain is not integrated with our network, and I think that's where you can help us start to integrate that so we can become strategic health providers and partnerships with the rest of the healthcare here. So the rest of it is a little video that we've put together. I think it's an edited version, but you have the link in the document that's been submitted for board today. So you can go to YouTube and watch the full one, which I would highly recommend that you do because it has some very pertinent points in it.
Why do you have to have blood tests?
Because I have hypothyroidism and my thyroid gland doesn't produce enough thyroxine.
Okay, so you're on a medicine, aren't you, called levothyroxine, and the blood tests show us what the thyroxine level is in your blood, so we can make adjustments to your medicine.
Yeah.
Yeah. How often do you need to have blood tests done, Abby?
Every few months.
It used to be very, very difficult, a nightmare, basically. They were fantastic at the hospital. They did a lot of desensitisation work. There was a fabulous team there, but it was torturous. And do you remember we took your doll and you used to go through taking the blood from your doll?
Yeah.
And then we'd try and take blood from you, but it was all very difficult, wasn't it?
Yeah.
And stressful, I think, not just for you, but for also for the nursing staff there as well.
Yeah.
There's various devices out on the market called upper arm transdermal devices, and these are like modern day leeches. So basically you warm up the upper arm, stick the device on,
and use a tiny tube to collect the sample in, and it's painless for that patient. So we did a little trial here with 20 patients, and we found one particular device that works really well with our patients with learning disabilities.
We went for Abigail's annual health check. When you're 14, if you have a learning disability, annual health checks start. We saw a nurse at the GP's, and she said, we've got a new way of taking blood that she'd just learned. Do you remember what it was called?
Touch activated phlebotomy.
Wow! So we call it
Tap.
tap bloods.
And she said, we can give it a go if you like. And I said, well, why not? And we said, let's try it now. And it was incredible.
It was okay and fun.
It stuck onto Abby's arm. They pressed the button on the side.
Okay. 1, 2, 3.
Oh,
That's it. Done.
we did it.
And then we wait.
And blood came out into the tube, and Abby sat there happily, smiling, and left the surgery that day saying, tap bloods is fun. And it was just crazy. I got back in the car and I was almost sort of shaking, thinking, I can't believe how easy that was compared with what we've been through for the last, 13 years.
It's made a difference to their lives, I like to think, and also the carers of those patients, and also the person who usually takes the blood from that patient, because for them I hadn't realised it's such a stressful process for everybody around that patient, not just the patient themselves.
It's absolutely transformed how I see Abby's future healthcare. She's had it done twice now, and she's quite happy to go. Very happy.
Tap bloods is fun.
So that's it. That's the story. Any questions?
Thank you. Thank you very much indeed. Slightly different story to normal, and raises all sorts of questions that I'm sure board members are thinking about. But for me, how do we encourage this sort of innovation, and how do we make sure we get this across our system? One of the things that really struck me was the patient centre, the patient right at the centre, but also by putting the patient at the centre, how that helps, it obviously helps carers, but also the staff, because it's not nice. That's something we often don't talk about. And then the final question for me is the strategic ask around the front end of the bloods process. So how can we look at that? And then, so shall I hand over to you, and then I'll let board members think of other thoughts.
Yeah, certainly, and I do really commend both the compassionate leadership that the staff in the lab team have shown, and the real development of this with patients and their families. It's how we like to work, so it's wonderful. I think we need to recognise, Chair, that this is what we call deliberate warranted variation. So this isn't something that because the cost of the device is not extremely cheap. This is deliberately targeted work for patients who we have currently, or up until now, not been able to work with as proactively or as effectively as we'd have liked to.
Yeah.
And I think that's a really important point. This isn't going to be how we test blood everywhere across the whole community. This is for people with who really, really struggle to have their bloods taken for a variety of reasons, particularly those living with learning disabilities and autism. And it really does smooth that process out. But what's particularly important about this is that we've talked about the 20-year gap in life expectancy and the huge health inequity that this cohort of really beautifully important cohort of our community experience. And this is going to enable us as clinicians to manage their care far more effectively. So a conversation that we have begun with the labs across the whole of Lancashire and South Cumbria is how we make this possible for our communities, not just in Morecambe Bay, but across the whole of Lancashire and South Cumbria, and that will form part of our clinical strategy and also commissioning intentions as we face into the future. Not without complexities, but we can't ignore this kind of innovation and then not make it more widely spread.
May I also just comment on that? Thank you, Andy, for all your compliments. as well as we have almost a flagship opportunity within the ICB here, because we have a varied population, a varied geography, and laboratory-wise, we have 3 different manufacturers of our analytical equipment, so there's variation in the actual analysis. So it represents, if we roll this out nationally, and I have discussions with NHS Digital, NHS Diagnostics and the Transformation Programme at the moment going on. They're very, very keen to support this, and North West Innovations have been hugely supportive of initial conversations at the moment, so we're hoping in the coming year this will be something that will be worked up, and with us as a flagship.
That's excellent news, excellent news. So I've got Silas, Tracy, Aaron.
Yeah, can you hear me? So really good presentation, and nice to see a new colleague joining us with the Pan Lancashire and Cumbria Pathology Service. Not really a question, it's just more of a comment. So from a sort of provider point of view, I'll make sure that we work closely with yourself, Andy, with our clinical colleagues, and I think we've got a great opportunity to spread a piece of innovation really quickly now.
Thank you, thank you very much, Silas. Tracy.
Thank you, Chair. I have to share this. I think, thank you. It was really great to hear all about this. I actually saw the piece on the BBC, so I was quite excited coming today to hear more about it. I think what Andy said about how this innovation needs to grow is, absolutely, and Silas's comment, absolutely the direction of travel. But I suppose for me, we got Abigail's very human story of the impact on one individual. How are we monitoring and measuring that wider impact in terms of that clinical impact? Because it seems to me that if we roll this out and this is something that can make a difference in terms of those health inequalities that many people in our communities experience, how are we getting the feedback around that in a more kind of data-driven way?
That's a great question, and I'm glad you've asked it. Thank you. So when we started this, we did a pilot of just 20 patients at Julia's practice at Carnforth. And in those 20 patients, we diagnosed 2 hypothyroid patients that had not been picked up before, one with a borderline HbA1c, so went on for diabetic investigations, and I think 2 with hyperlipidemia, so they were able to have either statins readjusted or initiated. And that was just in 20 patients, and these are patients that are never or very rarely able to give a blood sample. So we took that model of data capture and we've rolled this out across Morecambe Bay now, and we've just had a meeting last week with our 1-year set of data, which unfortunately the clinical biochemist has run out of time to finish it off, but we do have that data coming through, and we have picked up quite a few pathologies from being able to access these blood samples from patients.
Great. Come in.
Can I just comment on that directly as well? So it's one of the things that we commission, that primary care are commissioned to do, is to make sure that everyone on their practice list with learning disability or autism is coded as having that, and that they have a yearly health check. That includes a physical and well-being check. And actually, Julia has been such a champion of this work in Morecambe Bay that we were down at around 30% when she took over this in terms of people having that completed check, to well over into the 70-80% now in terms of completed checks every year. But the thing we were struggling with was getting the people having the blood tests as part of that check. That has also massively improved and increased over the last 12, 24 months since we've been running this. And so we've already got the proof that it makes a huge difference. A, that you've got people who really care about this work and drive it forward, but secondly, that it actually enables us to do those checks more effectively and pick up, exactly as Karen was saying, things that we were previously missing, which is going to have a big long-term impact on health outcomes.
Thanks, Andy. Aaron.
Thanks, yeah. Thanks, Karen. It's always nice to see a Morecambe Bay story coming to the ICB board. I promise I'll stop being parochial after a year or 5. For me, I don't think we can underestimate the importance of this piece of work, and it's through the lens in which Tracy's just explored the question, which is we often have a picture for our communities around health inequalities or population health issues, but I'm not sure we get curious enough as to the drivers of it. So I know for parts of our communities with LD and autism, there's often a conversation about, well, that's national and it's understood and it's for certain factors, could be genetic, could be the access to service. But drilling down to actually one of the causative effects is something as simple as taking bloods that's allowing us to understand a bit more about health needs and interventions and support is life-changing potentially. Particularly, you just mentioned 2 members of our community with pre-diabetic conditions and the treatment that can follow. So I'm really keen to follow up 2 things here. One is I'd like us to explore our role as a commissioner in the scaling and spreading of this practice. I don't mean generally, I mean this practice in particular. And I'd like to use it as a bit of a test for our approach to innovation, population health and health inequalities improvement. And we can do this in quite a stratified part of our community, Andy. So great to hear Karen's work at Morecambe Bay and Julie's kind of 30% to 80%. I'd like that to be in every part of our community where we have representative groups like this that need this kind of intervention. So I'm going to ask for an action there, Chair, that I'll pick up just to follow through. But I do have a question. So from the point of, I guess, the problem being identified and the Google search that led to we think there's a solution here, how easy was it and how quickly was it to get to deployment and implementation?
Thank you so much for asking that question. Yeah. So this is one of the not sticking points, pinch points. So we've been through the pathway, and we're talking about this nationally. I've kind of gathered laboratories across the country. We've got 6 other NHS trusts who approached me and asked for data, ethics approval, blah, blah, blah. How did we do this? How did we get it done? Here's everything, go and do it. And we chatted yesterday, in fact, how's everyone getting on? What are the difficulties with getting this established in a laboratory so we can provide this as a generational change in the way we deliver blood sciences, because this is new. We're not force-fitting a pathway that's always been there. We can access all sorts of people with this kind of testing or patient-centric sampling now. That's a thing. There's international groups working on this scientifically, of which thankfully I'm part of now. So in the laboratory, you need to make sure that the results you're giving on a capillary sample give you concordant results with a venipuncture sample. So we have to do this kind of reassurance in the laboratory that we know with our piece of kit from our manufacturers, it's going to give you a concordant result. Not identical all the time, but we flag that on the report so the clinician knows it's come from a capillary sample. So there's all of that work that needs to be done. That took us a year to set up in our laboratory. It was an MSc project from Joe Kilkenny, who got commendation for her MSc on this. And we've just had an MSc student finish down in Essex who's done exactly the same as us with exactly the same device on a different patient set. So we've got a lot of data coming through, but it does take time. What we're doing now in our group at Morecambe Bay is putting together a package for each of the 4 laboratories across our ICB to say, this is what you need to do. Here, go and do it. Unfortunately, that's come to a bit of a stumbling block just now because of the current situation we've got at East Lancs, but we will be picking it up as soon as we can going forwards. We've already scoped out who will be first to have a go with it. The other stumbling block we've got is that the TAP device is no longer available in the UK. But the company that make the TAP device, a chap called Kevin Kramer, who I think came up with the device and is one of the engineers and the CEOs of the company, he has been so invested in what we've been doing here that he has sent me a whole load of devices to see us through while we transition to another device. The only other device on the market at the moment that is licensed in this country for paediatrics and for adults is the TAP device, which is the one with the little blue button. Most of you will have seen it with a red button. That one's got a dry blood spot card attached to it. So for paediatrics, that's a wonderful new thing that's coming to market. The other ones are going through licensing processes, and I'm hoping in the next 6 to 8 weeks we should have a couple of those on the market. So we've got other options, and I've got a stack of them that they've all sent me. So they're really keen to give them to us to trial or to sell them to us to trial, to switch to for this patient group. And we've got a national kind of network now of laboratories that are keen to jump on board with this.
Karen, thank you. So one of the things I think it would be good to consider with the provider collaborative and maybe the federations is testing innovation and things like ethics approval once. Yeah. And there's a shared agreement that governance process is satisfactory for all. So one of the things to explore, if it's featuring one part of the system, that it's good enough that approval or that process is suitable for rollout elsewhere. So I haven't got an answer to that today, but there's a question to pose to make sure that we've got that ethics approval across the patch.
Yeah, we're working on that as a We've set up a national group under UK Laboratory Medicine, which is our professional association for clinical scientists. And we have now a special interest group looking at exactly that. The ethics approval is a nightmare. The group in Cambridge have managed to do it as a service evaluation, but I think Cambridge are very used to research and they know what they can do and what they can't do. Morecambe Bay was a nightmare, so we had to do the full ethics approval, which took about 3 months. And I have another project I'm hoping to start with one of those devices, but the time to put in to do the ethics approval is phenomenal, and we just don't have that resource in the laboratory. So to have someone within the pathology network, Silas, might be a lovely thing to have, someone who can support us with that going forwards.
Thank you, Karen. That was absolutely brilliant. And for me, a brilliant story about the power of research and innovation. Looking at a problem, having that drive to want to solve it, and then despite all the issues, doggedly pursuing that and innovating. And I think another question for us as an ICB is how we foster research and innovation across our patch, including the mechanics of ethics approvals and so on.
Yeah.
There are people in our system who kind of know ways to get round that, I was going to say. I shouldn't say it that way, should I? But to go through that.
It's such a grey area as well.
Yes,
yeah.
But I think generally it's such a brilliant example of what a difference it can make to actual patient lives and health inequality. So thank you.
Fantastic. Well, thank you very much indeed. That was really inspirational. And I'm going to pick up on Aaron's point. I mean, it raised so many questions about our role in reducing inequalities, about the opportunity to work across the system, but also how do we encourage innovation, and that conversation about the data capture, the ethics approval, the complications in doing these things. So I'm going to take Aaron up on his suggestion of an action. And I'd like it to come back to the board. We'll work out when at a point, but as a prototype in a way for how we use this as an example, but how do we get something like this across the system with the minimum fuss and the maximum efficacy. So we'll give you a date as and when we'll take that away for a date, but that's an action for the board. Thank you. Thank you very much indeed.
Thanks.
Well done.
Can I get my devices?
Okay, so that was a fantastic item. We're now down to my report, which you can probably take as read. There's not a huge amount to add, except that we have made 2 excellent appointments to the role of Deputy Chair and NEM. Both candidates bring a really wide range of relevant experience. Both will complement and strengthen the existing board. It was a really strong field as well, which I need to tell the board. And that, to me, that's a sort of reflection both of the progress that we've made as an organisation, but also the opportunities that we have as an ICB. So really delighted with that, and the next meeting, those 2 new non-executive members will be around this table. We've had a question from the public asking for the board's view on the Health Bill's proposal to remove the statutory requirement for local authorities on ICBs, and I thought I would address this as part of my update. I mean, the first thing to say is obviously we would comply with any statutory requirements, but the other important thing to say is the statutory requirement is the minimum. We currently do more than that because we have I have just appointed 2 local authority members around the board, simply because I think this board recognises the importance of that relationship if we are to make the changes that we want. So I cannot tell what the answer will be because I haven't seen what the statutory requirements will be, but it will in no way diminish the way in which we will work. So we will find some way of making sure that we have really strong representation both around the board table and in other fora as well. And finally, just a couple of words on today's agenda. It feels like quite a good balance today between the operational and the strategic. And indeed a good balance between the financial, which, you know, at the end of the day we have a real duty on that and it is very important, but also the quality and the outcomes that we are delivering, which is really where this board's interest it lies. So the operational, the performance report is, it's really good to see the new input from our new strategy director in terms of some of the narrative, which I think raises some quite interesting questions in my mind around the performance report. And the infection prevention control paper is an important one because we are not where we want to be on that one. And that's why I wanted it to come to the board. It does go through Quality and Outcomes Committee. In terms of the strategic papers, we have an excellent paper on the clinical strategy and how that will drive. This is about how we drive clinical input to all our commissioning decisions. So for that, it's a really important paper. And then finally, the case for change for our integrated urgent care work, which is incredibly important and will make a massive difference to the outcomes that we are able to achieve across the patch. So some interesting papers today. That's all from me. Very happy to take any questions. Otherwise, we will move on to Aaron's report.
Thank you, Chair. And conscious of time, Chair, given the items you've just reflected on the agenda, so I'll be brief in my update, but the paper's there for information if colleagues have got any questions. I will start in the way that I generally do with this report, which is a thank you to all our colleagues across the system, not just for the work that continues on improving the services and outcomes for patients and our performance and financial sustainability, but against the backdrop of some really complex organisational change, not just within the NHS, but I know a number of providers are also going through some difficult changes, and our local government colleagues are right at the forefront now of potential restructure and organisational change, which will be a bit more visible next week. So lots of leadership colleagues going through a lot of uncertain times, and believe it or not, leadership colleagues are also only human, and it's difficult to lead in that environment, but I'm very, very proud of the work that our teams are doing currently. That's reflected in our year end. So in our report, you'll see the reflections back from feedback on our annual report and our annual accounts and the auditor's views of how well we've performed. And we're just awaiting more formal notification of some of the more formal undertakings, we would call them, or requirements of us as an organisation from NHS England. And we've had some positive updates from region as to progress against those, and we can update a bit more formally in the next board, Chair. We are in, as just referenced, in the middle of our restructure work. That's due to complete this month with a recommendation to a board session on the 30th of July. Very pleased that our teams have come with, I think, an operating model that makes sense and enables us to take forward our strategic objectives. We'll be able to say a bit more on that at the end of the month. I am particularly grateful in the way that we've sent some of our proposals through consultation to broader partners across local authority and the VCSFE sector, and the feedback from colleagues across the partnership actually is helping us shape the final proposals. I'm really pleased with the feedback we've had there. We're also reaching a bit of a midpoint on our work to host the pan-ICB, across ICB specialist commissioning infrastructure, OPIC we call that. Had a good session with board colleagues this morning on that, so we look forward to bringing across new colleagues from the specialist commissioning teams in due course, and we start to work on the North West Specialist Commissioning Strategy for specialist services with our ICB colleagues across the North West. I didn't want to pass on this opportunity just to reflect on some reports and examples of where things in the NHS is not as we would want them to be. So we've had the Baroness Amos report nationally now on maternity services, and we've also had the update from the Fuller report around mortuary safety, just to recognise that both of those reports are with us. They're out with providers in our patch. We will play our full part as commissioners and supporters of improvements in quality and safety in taking forward the actions that have been asked of the NHS from those reports. I also need to mention the significant media coverage in recent weeks around the tragic death of Preston Davey and the conviction and imprisonment of those responsible for his death. And again, to just draw reference to the issues that were present through the case that was taken forward around those circumstances and the roles that a lot of the public services played around that and how we responded to that. Again, we will play our full part as a safeguarding partner across the system to ensure any lessons that need to be learned from that particular set of circumstances are taken on. I'm just going to end with a reflection of last week. We had the privilege of a national visit on Thursday from Dr. Claire Fuller, who leads on the national work around neighbourhood care development. We hosted that day with the national team with 60 to 70 colleagues from across the system. Again, very pleased to see representation from, I think, all parts of the system. It was a privilege to hear the stories from our places and neighbourhoods about the work that goes in to improving the experiences and outcomes for our communities. I was left at the end of the day with two senses of real hope and opportunity because of the kinds of stories that we were hearing and the reflection on scale and spread and consistency of that kind of work across all neighbourhoods, and we have some way to go, Chair. But that's part of the ambition, I think, in the new strategic approach. And then on Friday we met again with leaders across the system to talk about our collective ambitions and the work we wanted to commit into in improving the lives of all of our communities actually in Lancashire and South Cumbria. Again, fantastic day. We're just working through, Chair, where the 2 or 3 objectives or priorities we would want to set across the public sector that would only really be delivered if we all committed to them. So not just an adding up of everyone's issues and all of the actions we're taking, but just picking 2 or 3, and we're going to feed that into a board strategy session in September. So very brief overview from my report, Chair, but I just wanted to pull out those key points.
Thank you very much, Aaron. Any questions for Aaron or his report? No. Thank you very much indeed. So we will now move to the performance overview section, starting with the assurance report from the Quality and Outcomes Committee. Steve, am I right in thinking you are doing? Excellent.
Yep, sorry. So Julie, the chair of that committee, is on vacation and asked me to cover the AAA report, which I'm happy to do. So there's one alert that you've got in the paper in front of you, and this emerged from itself an alert in a report from the Primary Care Quality Group, referring to 1 or 2 CQC visits to our primary care contractors, and they weren't particularly negative reports, but what came out of the discussion was, why are we hearing these things from the CQC, and why are we not, as an ICB, with our oversight responsibility, picking these things up ourselves? And the chair, Julie, said the committee continued to have limited oversight of variability in primary care and sought assurance on whether themes arising from both proactive and reactive visits could provide stronger intelligence. So we got into then a discussion about the capacity of the team to do all the oversight work that it should do, and we heard from Jane and Scattergood and colleagues that that there was a problem with capacity. We asked about vacancies. There apparently are few or no vacancies. So it's the fact that the oversight group has been downsized. But anyway, it was always a challenge to do everything we would like to be doing in the sense of primary care oversight. Deborah made the good point that we should be relying more on data than actual physical visits. Nevertheless, the team is seeking to visit each contractor at least once in each 3 years, but obviously prioritising those where there is a problem, a potential problem seen. So in summary, the alert is potential risk that we don't have the capacity in the oversight team to oversee primary care in the way that we would like to.
And the mitigation, did we get to that?
I think Jane, you would like to.
Thank you, Chair. I think the mitigation is the drawing intelligence and thematic analysis from the data, the commissioning relationship from primary care commissioners with the practices, the architecture around primary care in federations, confederations, and the contribution of the LMC, and the capacity in order to do reactive visits. So proactive visits are helpful and they're supportive, but they're only ever a visit on the day and they're out of date the day after. So lamenting proactive visits, I think, might be too much of a distraction. We need to strengthen the work of a consistent and continued data feed. We also have, we accept complaints about primary care to the ICB, and we accept freedom to speak up alerts to the ICB, and we're rather unusual as an ICB to positively do that, so we do have some intelligence streams from the citizens we serve. Thank you.
Thank you. That sounds assuring. And I would just like to plug, as I always do, the importance of freedom to speak up. And I do appreciate that there is a cost to that, to the ICB, but it is really very valuable, as we have discovered. Okay. Any other questions for Steve? No? Okay, so let's move on to the AMR and antimicrobial resistance and infection prevention and control improvement priority areas. Andy.
Thank you, Chair. So, Board, the purpose of this paper is that we improve our oversight and assurance of antimicrobial resistance, of infection prevention and control, and really get to grips with the ICB's role and responsibility around antimicrobial stewardship. I want to start by really thanking a brilliant team of people who have done a huge amount of work to get us to where we are, namely Suzanne Penrose, Nicola Baxter and Hannah Goldsmith, who've worked really hard to help us, and it's a wonderful piece of collaborative work between our nursing directorate and our medicines optimisation team and the medical directorate. So really grateful for their expertise and commitment. This stems from a really important international call from the World Health Organization to recognise the huge growing problem that antimicrobial resistance is to the public's health, and a paper that NHS England released in a call to action in November 2025. And I want to be really clear on our responsibility and the requirements of an ICB, which is that we improve population health outcomes and provide organisational oversight, and that we particularly strengthen the governance in this work. There needs to be board-level leadership, which from now on will be overseen by myself. We will have a dedicated AMR and IPC board, AMR, Antimicrobial Resistance, IPC, Infection Prevention Control Board, which needs to be up and running and fully operational by December. It absolutely will be. We've already started that work. And then there will be appropriate reporting through governance routes, through the Quality and Outcomes Committee in particularly, and then to the board yearly for as long as we choose for that to continue. Now, let me highlight for you our three real priority areas that we want to focus on as an ICB. The first is to improve infection prevention and control in primary care, and you'll see in one of the appendices a big piece of work that's already going on around that. Secondly, we want to decrease the use of broad spectrum antibiotic prescribing across the entire system, and that's particularly focused on four groups, or what we call the 4 Cs. So coamoxiclav, quinolones, cephalosporins and clindamycin, and we've taken some big learning from the Scottish government where they actually banned cephalosporins in all of their hospital trusts and saw a massive decrease in superbugs and hospital deaths as a result. So it's very important that we take the learning from places that have already done this work and have done it well. And overall, we massively want to see a decrease in the incidence of superbugs across the system. And then thirdly, we want to see an improved level of appropriate prescribing of antibiotics in children aged 0 to 9, which again will be a big piece of work with our colleagues in primary care. So, being open and honest, we are currently not performing particularly well alongside other national systems, and are below national expectations currently, in particular key performance indicators, particularly when it comes to our rates of Clostridium difficile, with us being in the worst performing quartile nationally. But we've already seen significant improvements in the last 6 months, and will continue this trajectory through collaborative working with all partners and taking a system improvement approach, which we've already begun, and have seen the improvements in the last 6 months as a result. So we have clear priorities and actions within an achievable programme of work, and we are strengthening our governance and accountability. And what I want the board to do today is to really note and recognise the current gravity of our situation, agree the oversight of our 3 priorities, to approve the proposed actions, monitoring and oversight, and to receive a further report in July 27 and annually thereafter, whilst we also rely on both the new AMR board and the Quality and Oversight Committee to manage our governance in the meantime. Thanks, Chair.
Thank you, Andy. That was a really clear description of where we are. Any thoughts? Yes, Debbie, sorry.
Thanks, Chair, and thanks, Andy, because that's a really clear paper that you've set out for us, the challenge. I think you've shared with us why it's an important issue and sort of the impact from a patient perspective and sort of our position against it. And you've been really clear that where we are at the moment isn't where we want to be in terms of our communities, and a really clear roadmap and strong governance both in year and at the end of year about how that change will happen against those smart targets, all of which is really positive. When I read the paper, the bit that I was wondering about was it's really strongly focused on the supply side, so sort of the commissioning response, the how providers need to contribute and play a different role. I'm wondering about the demand side, because I'm thinking about the reality of a parent taking a poorly child to see a GP or in a hospital with a specialist, and that really difficult conversation that they have to have about, you might expect antibiotics, but actually it's not the right thing for you. And the more that we can actually raise awareness of that ahead of that interaction, the easier it is for the clinician, the better it is for the patient and for the parent as well. So I'm just wondering how that approach is factored in terms of our response as well.
Really good question. Andy?
It's a great question. And it's some work that we did previously, actually, when we were proactively doing more videos, which we were showing in patient waiting rooms. So, for example, around upper respiratory tract infections, around 80% of all ear infections in children are caused by viruses and don't need antibiotics. But when your kid's screaming and they've got a really sore ear and it feels really horrible for you and they've been up through the night, to try and say to a parent, actually antibiotics aren't going to be helpful, let's just manage the pain and you'll see that they'll get better in the next 3 or 4 days, trust me, it's going to be okay, is a really hard ask, especially when a clinician feels under pressure and the time constraints are small, are complex. So we did actually do a piece of work on this in Morecambe Bay a few years ago, and we produced a series of videos that we proactively sent out through social media and showed in the waiting rooms, and we saw a significant reduction in antibiotic prescribing in children with ear infections and upper respiratory tract infections as a result. I think what we need to do is take the learning from that, which we've probably let slide because of lots of other competing pressures, and actually reinvigorate that. But having a known clinician actually giving that advice, a practice nurse or a GP, and patients actually proactively, we can send these videos out proactively with the use of our digital technology now, even ahead of appointments, so parents can already have their head around whether or not antibiotics are probably going to be prescribed or whether they're going to be necessary. And there is some really clear guidance through something called the Centaur criteria through the National Institute of Clinical Excellence, which we're encouraging our staff to use much more proactively as well. Where this work happens, it happens really well, but it's about kind of it's about spread and scale and consistency of approach across the patch. So really appreciate the challenge, and it gives me a job to go and do. Thanks.
I've got Silas, but just following up on that. So when we do something like this, do we liaise? I mean, you're involved in all of this because it's sort of social media, various different media channels we can use, aren't there?
Yeah, we do. Yeah, we absolutely work really closely with different TIB programme teams to make sure we communicate, and then usually try and involve people as well. So particularly some of those engagement involvement mechanisms, try and involve people in the work at a really early stage. Great,
thank you. It's always the basic questions. Silas.
Yeah, thank you. So really important work, and especially I think for members of the public, why this is so important. If we sort of end up at a tipping point where our mainline antibiotics don't work, things like basic surgery no longer become doable. So things like heart surgery, major trauma, things like, because chances are you get an infection and we won't be able to cure the infection and leads on to consequences. So this is like a real big priority for health services across the globe, actually. I think in terms of the information sharing and spreading, count us in. So there's anything that we can be doing from a provision point of view in a hospital setting or community setting, you know, we're 100% behind you in terms of sharing information. The one thing the paper doesn't address, and it's probably because it wasn't designed to address it, is that the other big sort of issue here in this space is the widespread use of wide spectrum antibiotics in agriculture. And, you know, making sure that where they've got, you know, things like, you know, large densities of animals together where they're feeding them antibiotics in itself is leading to a lowering of their effectiveness. Is there more that we should be doing from a sort of public health, NHS, almost lobbying perspective about this? Because we can be doing all of this really good work, but if, you know, we're busy feeding our cows and our sheep and all these other animals these wide spectrum antibiotics, it's going to be really difficult in the long term to actually address this issue.
Yes, is the answer. I think we do need to use our lobbying power as much as possible, and I know that Professor Sir Chris Whitty would really welcome as much support as he gets in his conversations with DEFRA around exactly that piece of work. Silas, you're right, it's huge, and it is putting the public's health at greater risk by the vast use of antibiotics in agriculture particularly. And I think the other thing to note, Chair, is we've actually begun a research project across the patch as well on how many people are actually allergic to penicillin compared to who think they are allergic to penicillin, and there are some really good evidence now that we've prescribed penicillin to people who think they've had an allergic reaction, and then it's been coded in their notes forever that they're allergic to penicillin, when in fact they've then gone on to have cephalosporins, and you cannot have a cephalosporin given to you if you have a penicillin allergy, and yet they've been able to have cephalosporins really safely. So we're doing a really big, we've just started a research project around how many of our public are actually allergic to penicillin, because if we could get back to some of the basic antibiotic prescribing that we have available to us, it does mean that we're not then having to use the broad spectrum ones as readily, and that enables us to then fight some of the issues that we're having. So just to say, that's another piece of work that's going on alongside this.
Great. I'm not seeing any other hands. Really pleased that came to the board, because I think it was a very important discussion. I think we support the 3 priority areas, don't we? We approve the proposed actions and the wider actions that have come out of this. Actually, there's clearly an awful lot that lies underneath this. The monitoring and governance arrangements. Just so the board is aware, this does come on a regular basis to quality and outcomes, but I think it is appropriate for it to come again so that we can see the progress made in a year's time. Excellent, thank you very much indeed. So we'll move now to the integrated performance report, which is over to Alex.
Yes, thank you, Chair. So, as requested at the start, I'd just like to take the paper in 2 parts. Firstly, just to talk about the strategic context, and then to underline some of the headlines across our performance. So as indicated in the paper, item 1.5 and page 4, we are going through a transition as an integrated care board, and therefore going forward we'll need an enhanced focus on population health and an outcomes framework, as opposed to just a backwards facing performance report. So in practice, that is going to mean that we need a digital and a data environment that essentially is going to link personal level data, priority cohorts, risk stratification and inequalities. And that's really important to stress, because our integrated performance report at the moment isn't that. But I just wanted board members, members of the public to understand that is our direction of travel. But there is an awful lot of work that will go underneath that. And essentially, that will allow us to move into a forward-facing and hopefully eventually a predictable insight, so we can start to understand what we think is going to happen and to test that. That is the environment of a strategic commissioner. There's a further benefit of us moving to that approach, which means that we start to see the variations, and that could be warranted or unwarranted variations within our populations. Because at the moment, as colleagues, board members will see from the pack, we're dealing with system level metrics, which means sometimes we can't spot parts of our community that might not be receiving the care that they require, or actually the average of averages means we don't get into that level of detail. And as we heard from Abigail's story, we must always remember that every point of data in our packs is a person, is a patient, is a service user, and their stories, and therefore a population approach, a person-centred approach, will allow us to be more successful in our endeavours. That said, I do want to just briefly talk about the performance, because we do want to maintain a good focus as a strategic commissioner on performance of the system. I'm really grateful to colleagues in the teams, because as you might have seen, this period covers April to May, and I wasn't in post, so I'm taking some credit for colleagues who've done some great work, so I did just want to put that on record. It is important, again, for context, that we understand that we have a developing regulatory environment. So we're working closely with our colleagues in the region, NHS England, who are working directly with our providers now in terms of performance oversight, but we're doing that alongside them, which again may just take us as a board some time to process through roles and responsibilities. But for the avoidance of doubt and to ensure that we continue to be safe, we have kept all of the published performance metrics in our integrated performance report so that we don't lose anything. And I think that's important. Until you as board members are satisfied, we perhaps will over-report to ensure that we can be curious, we can inquire into any performance of the system. Grateful to the Quality and Outcomes Committee who received this report at their June meeting, so it has been reviewed through committee, and as we heard from a previous report, no escalations. However, I did just want to underline a few points, and then certainly if board colleagues have any questions. We continue to hear from our communities, our patients, that it's important that they are seen as quickly as possible when they're waiting for a procedure. And as you've seen from the report, there has been demonstrable progress in our elective care, which means that while there's still a focus on people waiting a longer time, that is going in the right direction, which again is one of our stated areas of performance. You may have seen from the pack that we again have made good progress in the community for children and young people, an important priority for us. However, there still is some further work to do with children and young people. And then finally, in terms of emergency care, our providers continue to perform well despite continued demand, and specifically around the 4-hour A&E target, which again we know is important to our communities, a sustained level of good performance. In fact, is showing stronger delivery than some of our partners across both the North West and England. Finally, Chair, we have got a update since the report was published. Blackpool Teaching Hospitals have had correspondence directly from NHS England because they have deteriorated in terms of their plan. So they have been asked to respond to that directly, but we are working with them on their recovery plan as a partner, and it will be through our governance that we report progress. That came after the report was published, but I wanted the board colleagues to recognise that process. So the report is there for noting, and happy to take any questions from any colleagues.
Thank you very much, Aaron. Any questions for Aaron? Yes, Tracy.
Thanks, Alex.
Sorry, Alex. Sorry, Aaron. Sorry, Alex.
That's what I said the wrong name. Yeah, thanks, Alex. What you've described in terms of that direction of travel, really welcome, being probably more strategic in the way that we look at the data. Something I just wanted to mention is that we sometimes, when we're looking at performance data in the way that you described, we don't always look at that kind of bigger piece around some of the longer term changes within our population. And it'd be very remiss of me not to say in this meeting that in Blackpool, we've actually seen an improvement in life expectancy. And although it's, you know, a small shift in the scheme of things, I think it's really important to say that there's been a huge effort around quite a lot of the indicators that I'd certainly like to see included in our report. Things like smoking cessation, things like those longer term changes in the population, in behaviours that have led to some of this. So I wanted to firstly say that it's really good news, because not only has there been that increase in life expectancy, it's actually bucking the trend nationally, and that's something that Claire Fuller picked up on when she came and visited us last week. but also if we start to understand some of that data better, we can start to then say, well, what has made the difference? How do we replicate that? And how do we do more of this really good work across the system?
Thank you, Tracy. Do you want to respond?
Very briefly, if I may. Absolutely, Tracy. So my experiences with outcomes as opposed to outputs or inputs, they are usually longer term and they're usually more difficult to demonstrate performance or impact. And I think a lot of NHS organisations have held on to that. What I think you're signalling, though, is how do we build up a richer picture on the way to achieving some of those bigger outcomes, be it life expectancy or healthy living? I think that's the challenge to us as a strategic commissioner now. I don't think it's good enough now that we say, well, it's really hard and it will be 3, 4, 5 years. I think we should know, and that goes back to our commissioning cycle, some of the things that are happening and be inquisitive to it. And if I go back to what I've just opened with, if we're doing that on a person and a place neighbourhood level, we will get some of that richness. I won't talk about it now, but the ability we have in analytics is so very different now than it was 6 months ago. So I think we can use the ability of technology now to do some of that for us that we couldn't do, which should excite us in terms of learning from what's going on. There's millions of bits of data being generated every single week in health and care. We're not capturing it all and we're certainly not doing anything with it. So I look forward to working with you on it.
Excellent. Look forward to it. Neil.
Yeah, it's just following on from Tracy's point there about local variation. Across Lancashire, there's some areas where life expectancy is through the roof and others where it's on the floor. And the data we at the moment is very much, vanilla. And understanding those variations is essential if we're going to make the biggest difference. I mean, if you think about vaccinations, it doesn't. At the moment, we've got figures here which show us sort of the average, and actually, that's not what's going to protect people. We need the 1% on the ones that are at 80%, maybe in East Lancs, is much more vital than the 1% on the 95% in Fylde, for instance.
Yeah. No, I think that's right. Raises a number of questions. I know that you are working on the performance report, and and that's very important. It raises questions about, because we do need to know what the outcomes are in terms of those constitutional standards as well, because we're held to account for them, and they are also very important to our population. So we need to know that. We need to know the inequalities and the richness of the place data. And then we also need to make sure that we don't just get completely sort of blinded by data. And as part of that, we probably need to think about who gets what where, because I think some of these conversations, we need the assurance, and it struck me as I was reading the report. Currently, we spend a lot of time understanding why things have been as they've been. And we need to move towards the predictive things that you've been talking about, but also understanding the board needs the assurance that that something's being done about where it's not right, and that it's being overseen. We don't need to know any more than that, but we do need the assurance. We need to have that sort of clear assurance. So I think there's quite a lot in there that we need to be thinking about. That I know you are, Jane.
Just briefly to pick on the same point, really. We don't yet have the richness of understanding about the interventions and what difference they're making. So where we're tracking performance, we don't have the insight that you described, for example, around smoking cessation. Now, obviously, you can't necessarily do it in that detail, but I think in terms of performance, that's what we need to understand, isn't it? What makes a difference and how we can track that through.
Aaron.
Yeah, thank you. And I'm delighted, you're right, Chair, it doesn't feel like it's only been 4 or 5 weeks since Alex joined us, but we've talked a lot at the board over the last 6 months about the importance of the commissioning cycle, demonstrating value and outcomes. So I know Alex is leading on a transition plan as we work through the new models and the way that we work, so this will feature as part of that next step. A couple of bits just to reflect back. Whilst we have an IPR, or a performance report that looks like this, which is predominantly around the performance we are seeing in the system currently, I do think in the interim we need to spend a bit more time in areas like general practice, primary care, community. It is still very, and we know why, but it's very acute focused, and I think in the interim period we could do with just drawing some of that out at board. The performance of the sector providers at the moment is to be commended. You can see improvement and sustained improvement. I just want to be clear that at board level, we have put in tens of millions of pounds worth of growth money into the sector, and that is the impact. We are seeing that sustained improvement. We just need to make sure that we're getting best value for that. So there's a triangulation, I think, Mark, Alex, on the investment and the growth monies and the performance we're seeing, so we can just get a sense of value for money. I think at board level would be something I'd want to develop, Chair. The final point I make is, Alex has referenced the change in the regulatory environment about the role of us as a strategic commissioner at NHS England region with performance oversight. One area that just kind of I'm conscious of at the moment is cancer and tiering and the oversight of cancer performance. We had a conversation with NHS England at our oversight meeting last week about the role of the Cancer Alliance and what we're doing as a system around cancer improvement. So I would ask the executive team with Alex's leadership just through the Quality Committee just to shine a light on cancer at the next reporting round, just so we can triangulate and see where that's sitting, if that's okay, Chair.
Yeah. Okay, so the value for money question. How are we going to do that? Is that something for? It's probably for Finance and Contracting Committee, is it? Or is it? Yeah.
I think so. I think there's just the contract performance and the performance that we're seeing around mandated statutory targets and the investment they've put in the sector. I think there is a piece of work that we probably do once a quarter rather than every month, just to make sure that we're getting what we have said the market could respond to for that amount of investment. I've got no doubt that that is the case, because you can see the improvement. I just think it's a discipline that we haven't quite got to yet that I'd like to see develop.
No, I think that's right. I think there are two actions really. One is that quarterly report which we're doing, but let's put it down there so that it's very clear in the board record. And then the second one, I think, is the one that is the quality and outcomes. I've just gone blank. Cancer, which is what I'd picked up as well. Yes, a particular report on cancer too. The one that really concerns me is 62-day, because it's come month after month after month, and we just don't seem to be getting the traction, despite what I know is a huge amount of work. Okay, so got two actions out of that. Any other thoughts or questions? That's provoked quite a lot of discussion. It's good. Fine. Moving on then. We are at Finance and Contracting Committee Escalation and Assurance Report. Steve.
Thank you, Chair. Obviously you have the two reports from the meetings on the 20th of May and the 24th of June. The 20th of May one, very much a matter of history, reflecting the exit velocity from 25-26, starting to move into the financial performance for 26-27, particularly looking at the first 2 months. But if I can start with the exit velocity, we, as an ICB and as a system, delivered what we said we were going to deliver, a balanced outcome where we delivered the control total, but that wasn't without the receipt of £40 million from the region and £167 million of DSF funding. So if you cut through those non-recurrent transactions, the reality is there's still £217 million structurally that needs to be looked at. And I'm going to try not to walk all over Mark's presentation, but that's what you can start seeing come through the operational plan, where we'd identified that we needed to deliver £250 million worth of savings to deliver our control total for 26-27, and they are significant challenges. There's a lot of risk in that, which I think we've recognised already. £36 million of which relates to running costs. And actually, whilst we are much better placed this year than we were last year to address those, with 100% identification in terms of cost improvement programs, by the time you risk assess those, you're probably getting down to about 85% using the NHS's risk methodology. So still a lot of work to do and deliver. But you can see in terms of the exit velocity that was a very positive one, delivering what we said we were going to deliver. In terms of the conversations, we also looked at all age continuing care, and you'll see that's a common theme through both reports, and it's probably likely to be a common theme through each report as we go through the rest of the year, if only because of its size and its likely impact. And I think in both discussions at both committees, we were starting to, I think, see some potential concerns around issues of processing, backlog, costs, etc. Certainly the second one, we took the decision that we would like some further information from the team, particularly in terms of how they're going to address these issues, so we can start work on them at the end of month 2 rather than get to month 8 and find ourselves staring down the barrel of a set of challenges. So we've looked at cost reduction programs, we've looked at the exit velocity from last year. Month 2 is reporting on plan, but again it's very early in the cycle. There is still a lot of work, and I've already highlighted, I think, a couple of big challenges, one of which is delivering the cost reduction programs. The second one is, as part of that, is managing all age continuing care. We also spent some time talking about commissioning, and again, particularly looking at the relationship between the Finance and Contracting Commission and the Commissioning Committee in terms of getting some clarity about what are the outputs we're expecting from commissioning, and then using finance to monitor that delivery. So I think we recognise there is still some work to do with that, and we look forward from a finance perspective working with the Commissioning Committee over the next, I guess, 8-10 months to try to firm up those relationships. And just a couple of other things. We spent some time at the last board talking about the green plan and visibility, particularly when we were talking about well-led. We did have a conversation, and the green plan is monitored through this committee. I think there's a piece of work to be done on further visibility with the board, which we'll take forward in due course. And we also had a look at the risks which the committee has oversight of. And again, one of those we sought to further develop in terms of the impact of all age continuing care, because obviously those two big finance risks are the key issues. And I think, as you've identified, Chair, finance can be important. It's probably important on the basis that if you don't have control of it, your capacity to steer your own course is severely limited by third parties, and that's not where we want to get to. That's as much as I'd want to say, but I'll take any questions.
And we're very well placed to comment on that.
We are.
Thank you very much, Steve. Any questions? I think probably should we move on to Mark's report, and then we'll take questions on both. Thank you, Mark.
Thank you, Chair. Thank you, Steve. No trampling there, so thank you very much for that. Just a little bit of detail on the month 2 performance position as per the report, and don't again intend to go through page by page. So this is the report as at May for this financial year. Again, to repeat a little bit, we have a challenging year ahead of us, but we are on a upward trajectory leaving 25.6. There is a minimum delivery of around 115 million that's needed across the broad headlines that Steve has already alluded to. And again, to repeat, we've got a series of mitigations in flight to manage those. As at month 2, we are still short of lots of our key pieces of information, so prescribing being one good example due to time lags in information, but using the information that we had at the time, again, we're reporting a break-even position in the year to date and indeed in the forecast. There are inevitably ups and downs, which you can see as set out in the report. A number of operational pressures emerging, which again I will draw your attention to in the pack. Some of those are a continuation, let's say, of trends in previous years and going over and above what budgeted levels were for the new financial year following some adjustments, and we've already flagged that to budget holders and SROs, and they are currently reviewing further mitigations to offset those. We still have absence, I suppose, of some contracting information as well. So again, very early in the year for that. If I give you an example, we're just reporting month 3 over the next few days, but we're still very much working on April's contracting data in terms of what we call flex and freeze dates. So, there is a time lag. It is frustrating, I know, at this time of the year, as we're all keen to get into understanding that monitoring, but we are working through that with colleagues. Just again to draw your attention to some of those variances, we've also got the benefits of some prior year from last year, so that's again where we make an assessment at the end of the year and more information comes through, so we've got a slight upside on prior year. I'd also draw your attention to the waste reduction plan, so the sort of the QUIP figure or the savings figure that's within our figures. Again, pleased with the progress in the first quarter of the year, so fully identified, but equally we're ahead of plan, which is obviously a good sign. What we need to make sure is that we continue to identify opportunities and work through those collectively. There is more information in the pack. There are still a range of issues being explored, other risks and issues as you'd expect in an organisation of £5 and a bit billion. There's lots of moving parts to this on any monthly basis, but we are working through that, and again month 3 reports will feature into the Finance Committee and obviously the board over the coming weeks. Just did want to bring the board's attention to one final matter. So we've agreed as a system that we will be holding a sort of risk summit, I suppose you would describe it as, at the end of July and early August. So a sort of triangulated view of both commissioner and or provider delivery, using the Q1 month 3 data, looking at aspects of finance, contract sort of activity and or other performance. We are meeting, I think it's the Friday the 24th of July, with CFOs, DOFs and the Chief Operating Officers, and then a follow-up meeting with the Chief Exec community shortly after. That will give us our first proper assessment, I suppose, of the system and the system position, but very much speaks to Aaron's earlier point about system working together to try and achieve the collective goal of, you know, delivering the improvement across the board, so that we've not got any surprises between us. So I think that's been well received by both the system and regional colleagues as a positive step forward. And again, it speaks a little bit to Aaron's point about the change in landscape. So last year, as we know, we had an external sort of agent in that process, which is no longer with us, but did help to identify risks and issues. And so we're going about that in the way that I've just described. And again, that will help us inform month 4, month 5 reporting in terms of moving forwards. So I will stop there, Chair. Happy to take any questions, but hopefully that updates the board on the position. Thank you.
Thank you very much, Mark and Steve. Any questions for Mark and Steve? Can I just ask that I got a bit muddled about the other services on your report, Mark. I know you. I don't think I quite understood what they, because there's quite. It's a big figure. I do appreciate we're very early in the year, so it's a. But just for clarity.
So one of the joys of our ledger, shall I say, not just this ledger, previous ledgers, is we have a certain set of cost centres that we can use for certain areas of expenditure. Everything else has to go into an other bucket, if you want to call it that. We have a very limited range of cost centres to categorise that expenditure in, so it's a bit of a catch-all. In there, you've got a range of programme cost centres. You've got, I'm going to say this word and I don't mean it, reserves or contingency. We don't have any of those, by the way, but anything that we do have from an allocation point of view flows into there. So we are restricted, let's say, in the way that we can report that, because as you know, we've got a national ledger system that everyone has to comply with. The variances, which might be more helpful to explain, which again you'll see in the report, therefore are a series of other issues. Some of that is a reporting sense. So if you give you an example again of the ledger, we have to show specialised commissioning positions in a certain way. We can't always do that. We have to show an offset, which you'll probably see as a feature in the report, and has always been the case. So it's not quite how we would want to do it, but unfortunately that's in part.
So what you're saying is it's not. You can't read into that variance as being something's behind plan. It's a mixture of all sorts. Yeah, got you. Okay, thank you very much. Any other questions? Yes, Aaron.
So one of the areas of delivery that we've got in our finance and improvement plan is around growth reduction, demand management, the management of contracts. And we've said before, part of the strategy is to try and stabilise performance, putting growth and investment out into the market, but also working with providers and places around work we want to do to try and minimise the investment in that area and still retain the same amount of performance. And the reason that's important is when we look at next year and beyond, we would like to use growth monies for investment in innovations and left shift, and not purely on increasing demand for service where we know we can probably change the shape of that demand. My ask would be, when we do the quarterly review, particularly with that triangulation between commissioning committee and the finance committee, is a risk assessment of those programmes, and to be thinking now about mitigations or other work that we might need to do to service the same end. And it may well be, I'm just with Silas as well in the provider collaborative, that heating up in the system of cost exposure for providers and expenditure for us in terms of commissioning we want to avoid a disconnect in quarters 2, 3 and 4. So really critical. There's a particular area of risk that I'm interested in exploring between the two committees, Chair, to bring to board.
Are you suggesting an action?
That there's a focused risk assessment of the bucket, as we call it, on growth and demand management with the Q1 review, and we have a look at mitigations in that area when we have the report into board at month 4 and 5.
Okay, I think I would agree with that. I would agree with that. It's quite difficult. It doesn't feature quite so meaningfully in the reports, does it? Okay, thank you. Okay, I suggest we take a 10-minute break. So back at past, please. Good to go? Bit louder? That means we all need to be quiet. Thank you. Okay, Mark, we're good. Okay, welcome back. We're now on developing the system and strategy section, and we are starting really pleasingly with the clinical strategy, which is something that I've been really looking forward to bringing to board. Over to you, Andy.
Thank you, Chair. So, Chair, the board is asked to approve and endorse the ICB clinical strategy as a really key component of the organisation's transition to becoming a strategic commissioning organisation. And the strategy provides the clinical framework through which the ICB will be able to identify its priorities, make commissioning decisions, and also improve population health outcomes, particularly for our communities who are experiencing the greatest inequities. It's intended to inform future iterations of our strategic commissioning plan and our wider operating model development. And it would be remiss of me to not give huge thanks to my co-medical director, Andy Curran, who really has led this work phenomenally and brilliantly, with the incredible input as well and help from Jane Scattergood, our chief nurse. I want to really emphasise the fact that this is a clinical strategy, not a medical strategy in any way. It's for all of the way that we think about our clinical input. And I particularly want to mention two individuals who've been phenomenally helpful in this work. One is Terry Worley, who's since left the organisation, and Jess Williams, who's just done extraordinarily excellent work in helping us shape it to where it's come. So it would be really remiss not to mention them both in particular. To emphasise, this is not a clinical strategy for the whole Lancashire and South Cumbria system. It's not a system strategy. It is a clinical strategy for the ICB as a strategic commissioner. And therefore, it sets out how clinical leadership, population health intelligence will work with a focus on reducing health inequalities and how that informs the decisions we make, the priorities we set, and the resources that we're going to deploy together. It represents what clinical leadership looks like within a modern strategic commissioning organisation as well. And as you all know, the ICB is undergoing significant organisational change as it continues to transition from a legacy commissioning model towards a more strategic role within the wider health and care system. And so the strategy supports that transition by ensuring four things in particular. Firstly, that we understand our population health needs and that drives our commissioning priorities. Secondly, that health inequalities and inequities are considered explicitly in all of our decision making and therefore how we work proactively with our communities. Thirdly, that clinical evidence and professional leadership are embedded within the strategic commissioning process. And finally, that our limited resources are directed towards areas where they can have the greatest impact on outcomes. So the strategy therefore forms part of the broader organisational transformation that's already endorsed by the board and provides the clinical lens through which many future decisions will be considered. The strategy is therefore deliberately focused and prioritised because we can't do everything everywhere all at once. So rather than attempting to therefore address every clinical issue across the system, it starts with an assessment of population health needs and identifies a limited number of areas where focused action can make the greatest amount of difference. And this reflects the board's ambition to be strategic and evidence-based and outcomes-focused. The intention, therefore, is not to create another standalone document. It's to provide a framework that influences commissioning decisions, our strategic planning, and the transformation activity across the organisation. And so a question to us might be, well, how can the ICB deliver this if it doesn't actually directly manage providers anymore? And the role of a strategic commissioner, to be clear, is not to try and control every aspect of service delivery. The ICB's role is to understand the population need, so to set strategic priorities, to align the commissioning decisions and investment, to influence partners through evidence leadership and collaboration, and to support a collective focus on improved outcomes whilst reducing health inequity. So the strategy actually strengthens the ICB's ability to perform that role both consistently and transparently. And the board may wonder, but how can the board and system know whether or not we're being successful in this? And so it's important to note that success will not be measured by the existence of the document itself. Success will be demonstrated only if commissioning decisions are increasingly informed by population health intelligence and clinical evidence, that resources are more closely aligned with our agreed strategic priorities, that the ICB can demonstrate a stronger focus on reducing inequalities, and that outcomes improve over time, particularly for communities that currently experience the poorest health outcomes. And so, just to be really clear, this strategy is not about directing every service across Lancashire and South Cumbria. It's about defining how the ICB will exercise clinical leadership as a strategic commissioner, and by grounding our decisions in population need, tackling inequalities and maintaining a clear focus on a small number of priorities, we can make better decisions, use resources more effectively, and improve outcomes for the people we serve. This is what we believe clinical leadership looks like in a strategic commissioning organisation, and we welcome the board's endorsement.
Thank you very much, Andy. So this has been through both Commissioning Committee and Quality and Outcomes Committee, and it has received feedback from both of those places. But this is the opportunity for the board to ask questions, to comment, but finally to endorse this strategy, as it will be a key driver of the way we operate going forwards. Thoughts, Steve?
Thank you, Chair. And Andy, you said up front that this is not a system-wide strategy, it's an ICB-only strategy. But you also say in your cover paper that there's been consultation with the rest of the system. So they're aligned, are they? There's nothing in here which is scaring them off?
Yeah, no, absolutely. That's a great question. And we have a fantastic relationship with all of our trusts and our GP provider organisations as well. Jane and I will in fact be meeting tomorrow morning, as we do regularly, with the chief medical officers and chief nursing officers. And we've worked very closely and collaboratively with all our partners to ensure that there's no secrets here. That's not the way that we work. We're not trying to spring surprises on people or to have misaligned priorities. Each trust has its own brilliant clinical strategy. Our provider organisations within primary care also have theirs. And what we're trying to do is make sure that very clearly that we're then aligning our commissioning with what the system priorities are and what the data is showing us and what the population health needs are. Our provider organisations are really attuned with that, they're aligned with it, they've seen it, they agree with this, and it allows us to then collaboratively focus on those agreed priorities and to make real progress on them through agreed actions. So, yeah, no surprises, lots of collaboration and lots of agreement on what we should focus on together.
Thank you. Thanks. Yeah, carry on.
So you asked a rhetorical question, how do we know if it's working or what? So how will we know if it's working? So as a committee member, it's quite nice to see sort of data and KPIs and things, and look, this is what we said we'd do, this is what we've done, and it's working. How do we turn this strategy into something that can be, if you like, monitored over time?
Again, it's through our governance and assurance processes. So we will be setting the clinical strategy is already agreed in terms of what we believe we should be focusing on. And we then work very closely with Craig's team in commissioning and Alex's team in transformation and strategy to ensure alignment of all of those things together. And then those things are then monitored through the data that we gather, which then comes back into our Quality and Outcomes Committee and other committees of the board to ensure that the things that we've set out as priorities for this board are in fact being delivered and improved on through system improvement approaches.
Thank you. Okay, I have got Tracy, and then I've got Alex, and then I've got Neil, and then I've got Debbie, and then I've got Jane. That Jane. So, Tracy.
Thanks, Chair. I think it's linked really to what Steve was asking about the kind of, this is setting out the direction of travel, and thanks, Andy, really useful, that summary. I'm sort of wondering how this is kind of linked to neighbourhoods and some of the work that I think will be the vehicle for some of this delivery, and how when we think about some of the ambitions within this strategy, particularly around those kind of pathways, that joined up care, making sure people don't slip through the gaps, how are we making sure that we're able to measure some of this through the neighbourhood work that's happening at the moment? Because we're all setting up in each place neighbourhood boards, we're all looking at neighbourhood health as kind of the vehicle, I suppose, for the way in which this strategy will be interpreted in terms of it being operational. Does that make sense, Andy?
Yeah, I think so. And let me test out whether I've understood your question with the answer that I'll attempt. And Chair, sorry, just to clarify, do you want me to take a few questions together, or do you want me to go one by one?
I'm just wondering, actually, because Aaron was just picking up with me as well on some of that area as well. Should we take a few?
Yeah.
I mean, because I think yours is quite similar in the sense of it's how are we going to know, which I think is partly. There's partly an answer to that in terms of the way in which we develop our streams of work, which are not quite there yet, but we will be come September. But there's also partly an understanding and an appreciation, which it's taken me quite a while of reading this to get my head around what it means for us. It's not your normal type of clinical strategy where you say you're going to do this, that, the other, you're going to measure it this way and that way, the other, and it's going to go to that committee or this committee. It's more of a framework, and I think that's what we're all, and it's worth getting our heads around this.
Yeah.
So I'm going to take a few more questions, and if you're not answered, we keep pushing, because it's really important. So, Alex.
Thank you, Chair. So 2 points for me. I think my first point was to respond to that, which I think there is still a piece of work for us to do to bring all of our strategic intent together. I think we're signalling to do that through the summer and into the autumn with the board so that we can really crisply answer some of those questions. But I also just wanted to make an observation from the content, which I think I absolutely support. Aaron said in his chief exec report that we had an executive leadership day on Friday, and really interestingly, some of those key themes that we agreed in a room of 60 leaders are present in this clinical strategy. So it means that we must be coalescing in the right direction. That room absolutely recognised the importance of place and neighbourhood as a vehicle for us to make demonstrable impact on health inequity, but it also signalled the importance of research, innovation, quality improvement, and digital data and technology. So I know that there are some crossover of people, but I think we should take heart that we're congruent in our clinical community development and a group of senior leaders. So that does give me, hopefully, some optimism when we do that overall strategic alignment. We're not going to come and do what perhaps we've done previously and have 27 priorities and try and do 27 things not very well. Actually, we may have a really crisp focus on some agreed strategic priorities.
Thank you, Alex. Neil.
Yeah, so my first point builds on what Alex was just saying there. We absolutely recognise there's a piece of work for us to do to communicate not just this, but the commissioning strategy and the operating model in a really simple way that helps people to understand what the ICB is, what it does. So we're absolutely on with that, and I think it builds on what Alex just said. The other point was just a bit of reassurance around the public engagement elements of this strategy. So we started off really early with quite a number of local people, communities in the room looking at what's really important as part of this, and we've built on insight work that we've done over the last number of months as well. So we know that some of the elements that are built into this absolutely address some of those things that the public say is most important to them, or things that they want to see improved, which we've shared in previous reports and through the commissioning committee. So just some reassurance on that.
No, thank you for that. That's very important. Debbie.
Thanks, Chair. It's similar points, really. I mean, I think it's a very clear, well-written strategy, and it was really positive to see that the feedback and the assurance that have been provided by both committees. I can see how it's been reflected in the refocused version, so thanks for doing that. I can see how the team have thought things through, and particularly the strengthening around research that's absolutely been taken on board. I think it's back to that point about strategic intent. So when I look at it and I think, okay, it's a framework, there's three bits for me that are really important that are critical to have in place, and there's the bit about workforce, there's a bit about digital enablement, and then there's also an aspect around neighbourhood capacity. And I suppose I'm wondering how all that fits together and how we can have assurance that the different strategies that we've got or the decisions we're taking together are lining up in that area to enable the strategy to work and have the impact we want it to.
Yep. Sorry, I left my mic on. Jane, and then I've got Silas, and then I'm going to go back to Andy.
Thank you, Chair. So I really enjoyed reading this. I thought it was a very clear strategy, and I think it says all the right things. I think the challenge we're all discussing is about an implementation of a strategy when we're a strategic commissioner, and how do we do that? And really that gets into the kind of system leadership role which we've talked about before. And just for illustration, there's a section in here on workforce, which I would absolutely wholeheartedly support, how we encourage our partners to kind of develop their staff, create positive, compassionate cultures. But in that area, for example, we're not directionally responsible for some of those things. So it is about leadership, it is about persuasion, influence, partnership working. So I think whatever follows from this, in terms of how we will do it, whether you call that an implementation plan or something that's a kind of roadmap, it has to be nuanced, doesn't it? To say, we'll do this through others, we will influence this, we will build this through commissioning. And that's the bit we're finding it hard to get our heads around, because it's not normally what you do when you manage something, when it's all in your kind of purview, if you like. So I think the what next is actually quite a critical piece of work where we tease some of these things out, particularly where we're not directly responsible for some of these things, if that helps.
Silas?
Yeah, thank you. So from a provider collaborative perspective, we were involved in the consultation of the strategy. We're fully supportive, and it's nice to see some of the feedback that we gave reflected back in the document. I think your description of it, Emma, about as a framework is quite helpful, because I think it's a framework for decision making and a framework for investment choices. And coming to your point, Jane, you know, yes, the ICP doesn't manage, but don't underestimate the ability to influence, and in particularly influence through money, what happens within a system. So I kind of leave that one hanging. I cheered everybody up at the leadership event last Friday by saying there's a key date in your diaries, which is the year 2044. This is the year of peak death, just to cheer you all up. And basically, sort of joking aside, is if you look at average mortality and morbidity rates, that's when it peaks in the UK, and it's the baby boomers going through their life cycle, basically, is what you're seeing. The key bit to remember in that is for the north of England, it'd probably be more like 2040, 2042, because of all the health inequalities that we have. And it's not like it's a flat line and then it suddenly goes up, it grows over time. So what we're seeing now today is we're seeing a doubling in cardiovascular disease, we'll be seeing a doubling in cancer, and we'll be seeing a doubling in mental health. And that's at the same time, well, the money will stay broadly the same, and the workforce, if anything, will probably shrink. So I think one of the things that we've got to get our heads around is, in that set of circumstances, what are the key multipliers that we can put into place? And what I mean by this, for every pound we spend of public money, we probably get £5 of value coming out. And I think it's some of the things that you've touched on, Jane and Debbie. It's about data, it's about diagnostics, it's about putting care into the most appropriate settings. It's stopping care where we're not adding clinical value to patients. And I think the next stage, I think, certainly from a provider perspective, would be working very closely with Andy and colleagues in the ICB to start thinking about what does our delivery plan start to look like. And then the other thing which I think also came up very strongly on the event last Friday is starting to really dig into, well, what really drives ill health. And there's no getting away from, there's loads of data now nationally and internationally that a key driver is poverty, and actually increasing social mobility, training, getting people to good jobs, using our money that we have as a NHS and wider public sector to put back into local communities and local businesses is a key bit about addressing poverty. And I think that should be something that runs like a, I don't know, Blackpool Rock I'm thinking of, you know, Tracy, but, you know, runs throughout everything that we do, basically, because I think that's the way we kind of really future-proof our system.
Thanks, Silas. Really insightful observations there, thank you. Okay, Andy, back to you.
Thanks, Chair. I've done it the wrong way around. It was on all before. Now there we are. So thanks very much to colleagues for great questions and provocations and questions. And so a few responses. First thing is to say, I think it really is a huge mindset shift from going from being a traditional commissioning organisation to being a strategic commissioner. And I think this strategy helps us begin to bridge some of that understanding of how the role of this organisation is dramatically changing. And we've done a bit of learning, which I've talked about at the board before, from the Nuka healthcare system in Alaska around a principle that they use around commissioning called tight, loose, tight, which is we want to be incredibly tight on what our vision is and what our priorities are and what we're going to focus on. And actually, when we then work into our different place-based partnerships and neighbourhoods, we want to say, we actually don't really mind how you do it. We trust that actually partners know how to work together more effectively in Blackpool compared to Blackburn, compared to Burnley, compared to Barrow. And we trust you to get on, but this is what we're asking you to do. And then we're very tight on how we measure and the outcomes that we're looking for and the data that we're gathering to check that that's happening so we can keep that commissioning cycle going into the future. And when we think about some of the examples both that we heard at the Neighbourhood Day on Thursday and things that we've heard about as a board over the last few months, we think about the frailty work that's going on in East Lancs. It's exemplary. Okay, so we know that's worked. We've understood it. We've codified what's working about it. Now we've got a very clear sense of this is actually what we now want to commission for the whole system. The same with the Morecambe Bay Respiratory Network. We know that it's significantly less expensive than other respiratory work across the patch. So now we know that's working. We can be really tight on what we want to commission. Actually, probably a little bit tighter on the model because we know that model's successful, and then tight on the outcomes that we want. Same with what we've just heard around how we're working with patients with learning disability and autism, or if we think about the work amongst child and adolescent mental health in Fleetwood, or the priority wards that we've heard about in Blackpool or in Lancaster. So we know that there are brilliant pieces of work that are happening, but what we haven't done very well up until now is codified that and spread and scale it and commission it consistently across the patch. What we hope this clinical strategy does, and we believe it does do, is to give us a real clear sense of how we do that better as a strategic commissioning organisation, that we don't just have little pockets of work that are excellent, but we learn from those pockets of work. We're a continuously learning system, and we embed that as practice across the patch. And we think this sets out, in agreement with our partners, what those priorities are. And I think because we've done a lot of co-production, both with our communities, thanks to Neil and his brilliant team, and with our provider collaborative board and with our GP providers at scale as well, it's meant that there's a cohesiveness and an agreement around, yes, these are the things we should focus on. And that makes our job as a commissioning organisation easier, because we've said, yes, these are the things we must do, so then we can commission it and resource it appropriately, focused on the inequities involved, and then we can begin to measure the outcomes and continually learn and see how we're doing across our various outcomes. So there are some critical things that you've outlined for us, Debbie, that I think we do need to pay attention to. We've come through a very, very difficult patch in the NHS, through COVID and then through various different reorganisations, and our workforce do feel quite tired and burnt out in lots of ways. What we really hope, actually, as part of this clinical strategy, is it brings a real sense of hope and purpose and clear vision about what we are about, and helps us build that culture of compassionate leadership across all of our provider organisations, which we are really helping to enable to happen. You're right that we need the digital technology and the data and dashboards to help us monitor and see how that's doing, and that's something Alex and I are collaborating on very closely over the next few months, and we'll be bringing things back to the board for some decisions for us to make about our capabilities in that space and how we improve further and faster so that this becomes more possible. And then to our neighbourhoods, it's absolutely all about neighbourhoods. Really, you could say this is a neighbourhood health strategy, because this is all about embedding it in our neighbourhoods, accountability, democratic accountability to our public and the people who we're really trying to serve. And if it doesn't make sense for Joe at the bus stop in Morecambe, or it doesn't make sense for Betty in the cafe in Blackpool, it doesn't make sense at all. And that's where it really has. So that's how we will know. We will know, yes, from our data, but we will know from the regular feedback that we get from our public whether or not actually we are meeting their needs and providing the services that they want and tackling the inequalities that they're experiencing. So it's a big vision, and it's a big ask, but it's also one that we think is right in terms of moving us towards a strategic commissioning organisation, and it is one that has been very closely co-developed with our public and our partners, and one which we hope will help us transition into the organisation that we need to become.
Sorry, Aaron.
Yeah, thank you. So I'm really pleased with the conversation that's prompted. For those of us that have worked in different parts of organisations in health and care before, it's an unusual document to get your head round. Ordinarily, you're looking at a case for change, a strategic direction, some measurements, some key trajectories, some reporting lines, and it isn't that. It's intended to signal to us as an organisation and our colleagues and the market that we commission where our priorities are sitting and the approach we want to take to try and drive improvements in these areas. That's what the framework is designed to do. But we won't be able to get away from, but this framework then will be pointed at our planning and our prioritisation and our delivery ambitions, and therefore will shape things like what does year 1 and 2 of the successful delivery of that look like, what's the 5-year trajectory, how does it inform the 10-year ambitions we've got in the 10-year plan. It sounds like we're placing a lot of stock, Chair, in the autumn period, but just if I ask colleagues just to zoom out, so we have very clearly a blueprint and a set of requirements now as a strategic commissioning organisation. The commissioning cycle will then tell us through the data where we need to focus our attention for that to be successful. We then move that into a view clinically across the system as to what interventions and what ways of working do we need to introduce as a commissioner for those things to be addressed. That's where the clinical strategy becomes really important, because that's the framework. We then move to the commissioning cycle as who's best placed in the market to help us deliver this, and then we move back again around evaluation and assessment. So if I can ask colleagues, every time we bring a piece like this, we probably need to have an overlaying paper which is about that commissioning cycle, where does this sit in that, and how is it helping us shape the final phase of our strategic commissioning journey. But even taken in isolation, it is a really well thought through, well considered, well narrated framework that allows us to build lots of stuff off. So I would commend it. I think I was the same as you, Chair, took 2 or 3 reads to get my head around my old world of a provider chief exec and a strategy document, because it isn't that, but it is a very, very good piece of work.
Thank you very much, Aaron. So trying to summarise a very rich discussion, first and foremost, I think there is great support for this, including the priorities that have been identified, because we're being asked to support those as well. There is clearly, I would like to see, we need to have in our heads your description of the commissioning cycle and where this fits, and I think we could do with this, but so could the public actually, because this is part of my ongoing thing of what is it we're here to do. It's quite difficult to describe an ICB sometimes, so I think there is some work to be done around that, which I know you're on, Neil, and collate, it's a sort of collation and communication piece. And then I think, and that will help us work through what the implications are for how we work, including things like the spread and scale. And the next agenda item is a really good example of this in action, of course. So thank you very much. I think there is great support for this. Really good to see it. And I would like to reiterate my thanks to Andy Curran, who isn't here, but I know did a huge amount of work on this. Thank you very much. So now we move to the next item, which does follow very nicely on from this, which is the case for change for integrated urgent care redesign. Again, this is with Jane Cass.
Yeah, thank you. Thank you, Chair. So the paper that you have in your pack is the case for change for the redesign of integrated urgent care services across Lancashire and South Cumbria. Not going to go through that case for change in detail, but what I will do is draw out some of the contextual information, so it will set this into a framework for decision. Important for us to understand exactly what we mean by integrated urgent care, and this is a collective term that brings together all same-day unplanned urgent care services outside of emergency departments. So that includes urgent treatment centres, GP out-of-hours, clinical assessment services and walk-in centres and minor injury units. In terms of the context for the case for change, currently our IUC services are fragmented and inconsistent and inequitable. 12 legacy contracts delivered by 8 providers leads us to have significant variation right across our geography, which gives us variation in access to quality, digital capability, workforce models and cost. Demand for urgent and emergency care is growing faster than capacity, placing increasing pressure on emergency departments in general practice. And maintaining the current arrangements is just not sustainable for us in Lancashire and South Cumbria, which means that a system-wide redesign is required. If we're going to achieve our vision of developing modern integrated urgent care system that's capable of meeting our population's needs in the next 10 years, if it's going to deliver equitable access, be digitally enabled and really strengthen collaboration between providers and partners, we really need to change how we deliver our integrated urgent care services. Existing services were largely designed before COVID and are no longer reflective of our patient behaviour, technology and the healthcare demand. We've got historic commissioning arrangements that has led to significant variation, and many of those have been transferred from CCGs of old, and we haven't then been able to start to look at different ways of doing that. Reprocuring existing contracts, so doing things in the same way but just reprocuring our contracts without any redesign will perpetuate our outdated models of care, so we really need to look at redesigning those and then recommissioning. In terms of the strategic drivers, they are really clear within the case for change. I'm not going to go through those for you, but very much in terms of our 10-year plan, our 5-year strategic commissioning plan, and all of those other national drivers. And of course, our current performance challenges are not, we understand those really clearly, particularly in terms of the attendances to EDs, which are significantly increasing, especially in terms of emergency admissions, which are 20% above the national average, and the growing demand that we have within our general practice, which is all contributing to the position that we find ourselves in. Monthly consultations in general practice have increased from 750,000 to 880,000, and online consultations increasing each month. We've also listened to what our patients have told us as part of our patient engagement, and you'll see that written clearly within the case for change, which is really important. They've highlighted the need for 24-hour urgent care access, far better public awareness of available services, clear and consistent service naming, community-based health hubs and virtual care options, amongst others that you'll see in the case for change. Obviously, finance is critical to whatever we do as we move forward, so that's definitely part of how we're redesigning our services as a proposal. Current spend on our integrated urgent care varies considerably between localities, so we don't have consistency of spend. We've got historic contracts and varied service models, which makes it really difficult to compare costs by localities. And we've got multiple providers and contracts which create inefficiencies and sometimes duplication as well. Modernising our offer for integrated urgent and emergency care will afford us the opportunity to really look at economies of scale, to reduce duplication and to improve financial sustainability, which should then lead us to have better value for money. There are some real key risks that are listed in the case for change too that we shouldn't forget. These are particularly around the procurement process and the complexities around such a large procurement process that we're proposing as part of a case for change. The workforce and cultural changes that will be required for any model that we do commission in the future. The digital interoperability challenges that we'll face, so we'll need to work really clearly with Alex and his team and certainly with our providers and partners. And the risk of misalignment with wider UEC programmes too. So we need to make sure we're pulling all of those different strands together to ensure a comprehensive approach to integrated urgent and emergency care. But notwithstanding that, there are some real key benefits to redesigning our services. And again, within our case for change, you'll see those. But certainly we'll be looking to benefit from more equitable access to urgent care, reducing ED attendances and the pressure that our hospitals are currently facing, consistent service delivery across the whole system, improving workforce resilience and better patient experience and better patient outcome, which will then respond to some of the points that we're hearing back from our patients and the public, and greater financial efficiency. So finally, as part of the case for change, you'll see two proposed timelines. One of those is set out where public consultation is not required, and one is where public consultation is required. And it's set out in that way because as part of a case for change, we will not assume that a consultation is or isn't required. We'll certainly wait for, as we work up the options and the consideration given to the next steps. So should a consultation not be required, our go-live date could be June 2028. And should a consultation be required, go-live date approximately September 2029. So that's reflective of the significant amount of work that will be required to undertake this, this redesign. So overall, the status quo is not sustainable. We can't continue to recommission the services as they currently are delivered. Our IUC services are fragmented, and a redesign of those services will help us to meet, to relieve the pressures on hospital and primary care, and also to meet our future needs of the population that we have. Just bringing it back to the paper in the pack, you'll see two stages set out in the cover paper. Stage one is relates to a reprocurement of the whole IUC services in West Lancashire, and then stage two, the transformation for the rest of the system. Just to note for today, there is ongoing work on the reprocurement of the West Lancashire services. That's currently still being progressed, and we'll bring that back here at a later date. So in terms of the recommendations, we're looking to approve the case for change and to note the work in progressing on to the next stage of service change process, which is the options appraisal. And I'll pause there, Chair.
Thank you. Thank you very much, Jane. So, as I've said previously on case for change, the purpose of a case for change and for the board approval of it is because we believe there is a case to change the services in a significant way, and we want to have a look at it. We're not saying that it will necessarily change. We're not saying it will necessarily change in a particular way. We just want to look at it. So that's the context of what we're being asked to do. It's a helpful paper because it sets out very clearly the issues of the current service, and I'd just like to open up for any board comments on that before I ask for any decisions on the case for change. Aaron.
Yeah, just to I think the document's really good. I think it's really articulate and evidence-based. I've got two questions that I think we need to consider. One is the case for change is stark, but it draws as drivers for a case for change review demand, performance and capacity issues in urgent care. So I think one of the things we'd need to consider alongside this is what other work are we commissioning in the system to reduce demand for this type of service, whether it's in population health, health inequalities or alternative neighbourhood and place models that don't necessarily lead to the kinds of activity that we're seeing in some of the points of contact you've mentioned in the IUC service. So there's a growth and demand element to this that doesn't feature in the case for change, but I think we need to think of that as an alternative piece of work, and it's probably in tandem, Chair, to look at the options there. The second then, if there is a support for exploring further and the case for change develops, because something needs to change, because the case for change elements are clear, I am still getting used to commissioning cycles, Chair, and timescales, but when you hear 2028 and 2029 where a case for change is stark, that doesn't intuitively feel right to me, and I'm sure there are reasons why in terms of due process and timescales. My challenge would be how quickly could we do this to get to a position of we want to take this forward, and after that, how quickly could we get to a decision in a change cycle, because that feels a long time away to me, Chair. So a question and a reflection.
Yeah, I have to say I completely agree. I was caught up in the timescales as to how it could possibly take that long, because it's so the case for change is so stark. Alex.
Thank you, Chair. So I think this is a perfect example, again, from a patient, a person in our community, about the lack of connectivity in different parts of the health and care system from a digital point of view. So I'm really happy to see it. I think we should push ourselves in terms of how much digital data and technology could help, and that might accelerate some of the timeframes, because ultimately a shared care record that's got visibility of all of our partners is the right thing for that patient, for that service user, but also for the providers as well. And I think this, I know it's mentioned in there, Jane, but really having that at the forefront of our use case now, otherwise we might just design in some of our fragmented technology again, and I just think we need to enhance it a little bit more, if that's okay.
That's music to my ears. We have a neighbouring ICB that has an exceptionally good shared care record, which I'm really keen to get. Sorry, I thought I saw another hand. Just following on from that, I got you, Tracy. Just following on from that, and also picking up Aaron's point about, you know, stark, what can we do to reduce demand? There is almost a sort of interim solution, isn't there, that says what could we do with the current providers if we had better systems and if we reduced demand? Would that create a different case for change? And I don't think we would want to pause this because it's so stark, but I do think there is something about, isn't there a quicker solution, a quicker and more immediate solution? The other thing that strikes me is this is such a big piece of work. It is a huge piece of work. So if we can break it down into bite-sized pieces, that would also be useful. Sorry, Tracy.
Thanks, Jay. Yeah, my sort of observations follow on nicely from that. I think there are some things we can do. Jane, you talked about the different language that we're using to describe services. I think some of the feedback from patients is very much around, I don't know where to go and I'm not sure I'm in the right place. So I think what we're doing is we're pushing a lot of demand to emergency, ED, A&E, and not intending to do that. So is there something now that we can do around improving the understanding so we're not creating more traffic to somewhere where we want to reduce that demand? And obviously, Aaron, your point about the earlier interventions that we need to think about, so we're not designing a service to provide for something where we should be further upstream. And just a point of accuracy, and again, it kind of goes back to us really understanding what we've got at the moment. Just on page 11, it says there isn't a walk-in centre on the Fylde coast. Sorry to be so pedantic, but there is. And I suppose it plays into that. If we can't describe exactly what we've got across the system, we're probably not communicating really clearly to our patients exactly where they should be going in all the different scenarios that they're experiencing. And I think to me that's the most important piece of this change, that whether you live in Blackburn or Burnley or Blackpool, you understand where is the right place to be when you've got an urgent need, when it's not ED.
Debbie.
Thanks. I think for me as well, we might have a model that we think we would like, but we're going to have the workforce to deliver it. And that takes time and planning, doesn't it? So, and I think that's why a number of models in the past have failed, because we've got to transition from where we are now to that future way of delivering care. And we've got to build, it takes many years to build a workforce that is much more focused in the community and keeping people out of hospital, etc. And that is usually the stumbling block, isn't it? And the affordability of almost double running while you're moving from what you've got now to what you need in the future. So it's just that play that, in looking through this, there's not much in here about the future workforce that we're going to need. Where are we going to get them from? And how long is it going to take to be able to have a workforce that's fit for the future? Sometimes as well with these strategies, by the time it's developed, it's out of date, isn't it? Mm-hmm. Because if you look at this, we've been talking to people in 2024 and we're now halfway through 2026. So it is that thing about, I think back to Silas's point before, we've got all these things that are coming in the next 10 years. We really need to be building something that's fit in 10 years, not building for the gaps that we've got now, I suppose. So it's those 2 points. But I think the workforce is the real biggie, because you can commission what you like, but if you haven't got the workforce out there, we're not going to get people to deliver, are we? I haven't got the answers, but yeah.
Do you want to come back, Jane?
If that's okay. So just to Debbie's point, really important, and it isn't in a case for change, but you should expect that in an options appraisal. Really important points as a reminder, and they will be taken into account. Completely understand and agree with your nervousness around timelines, and also the enormity of this work. So breaking that down in maybe in phases, or how we do that, I think we can show that in a different way. You're absolutely right. We should not stop the work that needs to be done now to address some of the immediate pressures, whilst we start to look at what our services could and should look like in the future. So things like demand management, things like the upstream work in terms of prevention, navigation to the most appropriate places, and language and how we describe our services, really important. We shouldn't stop doing that, and we will continue to do that whilst we then investigate what our potential options could be for the future. And take your point about Falco's, I will take that back. But as you said, Chair, this is about an opportunity for us to pause and to look at our services and consider whether a redesign is appropriate for us across Lancashire and South Cumbria. I've got Silas in my mind here about the 2044, thinking, oh my goodness, that's me. So what services would I want as we approach that time as well? Hopefully it will be a service I need that will discharge me, Silas. Yeah, that is what I'm worried about. But I think this, the considerations that we've given to this today should help us to then move on to what could those options look like for us for the future. Thank you, Chair.
Thank you. So just trying to summarise, it was a good discussion. And I think there's support for the case for change. I'm right in thinking that, yes. But I think with some nuances, because whilst you say we need to carry on doing the navigation and the demand management, we aren't terribly successful at either of those at the moment. So I think carrying on is possibly not the term I'd use. So I would like to, in a sense, I think it's probably helpful to wrap up into the case for change. What are the short-term, immediately quick wins that we can do? That would certainly include demand management, navigation, communications. Some of the medium term, certainly in terms of these timescales, might be around some greater system operability. But then there are some longer term things that, as you said, need to look to the future workforce, and they look to the future model. But that future model might not be the same, having looked at all those interim solutions, as they would be if we sat here today and tried to design it. So I think if that's helpful, that's a slight amendment. Excellent. Thank you. Good. On to governance and assurance, starting with the Commissioning Committee Escalation and Assurance Report. Debbie, thank you.
Thanks, Chair. So there's two AAA reports to share with you today from the last two meetings of the Commissioning Committee. So there's a report from the 20th of May and then also from the most recent meeting on the 17th of June. So I'll draw out a couple of points just for attention, really, lots of which connect actually with today's agenda and some points of reflection, really, in terms of conversations that we've had. So looking at the 20th of May meeting in AAA, there's no alerts from either of the meetings. We obviously looked at the draft clinical strategy and also the integrated urgent care redesign case for change that we've just looked at. So you can see really clearly there and helpfully sort of the feedback that the committee shared that's been taken on board and hopefully supported the board when it's looked at those two items today for decision. Under Assure, I just wanted to mention that the committee received an update against children's ADHD and hyperactivity and ASD assessment services. Obviously, we've seen in the finance report around the escalating costs. We've seen in the IPR report about the demand and the volume still continuing and actually increasing. So the committee did receive an update around the pathway redevelopment work that's relevant there, and we've asked for a further review and an update in another 6 months' time. So we did receive some assurance in terms of the progress and the impact and the framework that's in place, but we did want to take another look at it to look at impact in 6 months given the challenges in lots of different respects. And there was also a couple of points around primary care. So just around primary care assurance, just to note that the committee was assured and received a copy of the primary care assurance framework that has to be completed for delegated services each year, and we're assured against that. For the 17th of June, a couple of mentions. So we looked at a couple of PCBC, so apologies for the abbreviation, so pre-consultation business cases. We looked at one for Furness District General Intensive Care Unit and received an update against that, and were able to offer some feedback in terms of its development and some testing of the approach that was in place, particularly around communications and engagement strategy that's being developed and delivered. And we also had a look at the vascular reconfiguration programme, pre-consultation business case. And again, we offered some feedback, and we also noted and supported ongoing engagement with the health overview and scrutiny committees around that development moving forward. And then finally, we received a really valuable bi-monthly update from Neil around working with people and communities. So it had a strengthened focus around commissioning-related engagement that had happened in the past couple of months that was really positive. And we also saw and endorsed the draft communications and engagement strategy for 26-29 that underpins the commissioning approach of the ICB. There was some minor feedback which I know the team will take on board. One point actually interesting was about what we've just touched on, being supporting the public to be clear about what it means for the ICB to be a strategic commissioner, and that sharp focus around impact measurement and outcomes as well. So happy to take any questions, but hopefully that's drawn out a key flavour really.
Thank you very much, Debbie. Thank you very much. Any questions for Debbie? No? Excellent. I mean, it's starting to find its feet, isn't it, the Commissioning Committee, which is really good. Excellent. Good. So now let's move to the Audit Committee. Steve.
Thank you, Chair. This was a single issue Audit Committee. If you remember, we met 1 hour before the board meeting, which approved the financial statements and the auditor's report and the internal auditor's report on the 15th of June. So there's no real alert from this meeting. You all heard the reports from that committee at the board meeting an hour later. The only thing I would mention again is that the internal auditors gave us moderate assurance this year, which was an improvement on the previous year where they'd split their decision between moderate assurance on everything except continuing healthcare adult AACC, and where we had limited assurance. So that's a step forward. But the next substantive audit committee meeting is next week, so there'll be more to report after that.
Thanks very much, Steve. I'm assuming there are no comments on that since we had the board meeting afterwards. Excellent. So North West Specialised Joint Committee escalation. Jane, are you going to take that?
Yes,
yeah.
I'll take this. I think neither Steve nor I were at that meeting, but I'm happy to talk to the report if that's okay. So there were a couple of areas at the meeting at the 29th of April where we brought back to board to alert. The issue and risk around adult critical care transfer service remains. I think this may have been presented to a previous board too. And this is due to the absence of the capital funding, which prevents the procurement of a service that will be compliant for that particular service. A joint letter has been issued to the national team to seek confirmation of some capital funding to be able to go out and procure that service, and that was currently being followed up by the North West team. In terms of ongoing pressures, you'll see from the report that We continue to report on pressures around cardiac waiting times, cancer, renal dialysis and breast screening delays. In terms of breast screening, a trajectory for improvement is currently being worked up by one of our trusts and seeking some short-term additional capacity to be able to mitigate the immediacy of those risks, with some longer-term actions to be taken to ensure that this risk is no longer one that we will be able to accept. And also in terms of cardiac, so mutual aid providing short-term capacity has been sought from across the Northwest to help with one of our areas across who delivers cardiac surgery. However, we have discussed at the Northwest Committee that a more robust and joined up approach to how we operate in terms of mutual aid in the future is now more appropriate, given that we can't continue just to seek mutual aid on a short-term basis for our patients. And then finally, the one that I just wanted to pick out was the closure of St Andrews Healthcare, which continues to create system pressures for secure mental health provision and bed capacity nationally. But to note that no specialised service patients from Lancashire and South Cumbria reside at that particular facility, so no direct impact for us here. And then in terms of to advise, just to put out that we are continuing to have our conversations around the Office for Pan-ICB Commissioning, and they will continue to be reported through the North West Specialised Commissioning Committee as part of our governance and assurance.
Thank you. Any questions? Yes, Steve.
So it's not a question, just some assurance. The adult critical care transport services issue, James is right, the issue is that the 3 ICBs in the Northwest are supposed to be, the requirement is that we procure a service between the 3 of us. And that has not yet happened because of the capital funding that uncertainty that Jane referred to. However, the assurances that we got was that each ICB has made interim arrangements which are satisfactory. So it's not as if this service doesn't exist in our 3 ICBs. It's just that we haven't yet reached the pan-Northwest procurement situation that we're supposed to be reaching.
And will that be made better or worse by the the OPIC transfer? I'm just thinking about, will we, if we're doing something across the system? So I think there are a couple of questions for me. One is that why is that an alert? It's an alert because it's an issue for us from a process and a sense perspective, but we're saying that actually from a patient perspective we are safe and it's mitigated. But will it make any difference? Will it make any difference when we are hosting it? Will it make it easier for us? Will we have more control over it, or is this just because we're struggling to get capital monies out of NHS England?
I think it's the latter.
It's the latter.
Yeah, it's the struggling to get the capital money. So there is a strength of voice across the Northwest at the moment through the Northwest Joint Committee, and we will continue that through the future arrangements. So I think it's just a funding issue with the national team.
Okay, thank you.
Neither Jane nor I draft these reports. This is not a subcommittee of this board. It's a general sort of pan Northwest committee. We don't draft those alerts. I wouldn't have made it an alert, but since it's there in red, I'm alerting you.
Thank you. That's really helpful. Deb.
Yeah, thank you. Sorry, just point of accuracy. It is a subcommittee of this board. It's a joint committee of the 3 RCBs. But I recognise your point, Stephen. I think that again, there's an opportunity, when we think about how we really embed different ways of working going forward. Thank you.
I think you're saying we don't have control over the servicing of the committee. Okay, thank you. Fit and proper persons test. This is the annual submission that we have to make over fit and proper persons on the board. As such, it's an important declaration that we make, and I'm very grateful to Deb because there is quite a lot of work that goes on behind this, collating information from various sources, some of which is easier to collate than others. So over to you, Deb.
Thank you, Chair. And as you say, this paper provides assurance that the RCB has completed its annual fit and proper persons test core requirements for all board members, and that's in line with NHS England's statutory guidance around fit and proper persons that came into force in 2024. So the submission covers the period of 1st of July 2025 until 30th of June 2026. To support the Chair in signing and submitting the declaration, a number of internal assurances were provided, which are outlined in the report. The annual declaration was submitted on the 30th of June in line with national timescales, confirming that all board members have been assessed as fit and proper and there were no issues or concerns identified, and a copy of the submission is attached for completeness.
Thank you, Deb. So that has been submitted and it's here for information. Moving on then, use of the seal, Deb.
Thank you. So very briefly, the RCB has a seal, and under our constitution we have to report any use of the seal to the board on a biannual basis. The last report was in January 2026, so this follows as the biannual update. The seal's been used once in that period on the 31st of March 2026, and that was to seal a freehold grant agreement, details of which are summarised in the report. So the board's just asked to note the use of the seal.
Thank you very much. Duly noted. And then finally the report concerning matters that we considered in private.
Thank you. So the board has met on 3 occasions since the last report, 14th of May, 4th of June and the 15th of June 2026. Considered a range of matters including progress against our improvement actions and enforcement undertakings, updates on organisational change and staff consultation. There was an update on the SEND reforms and the RCB's part in informing local authority submissions. The board have discussed and considered service change proposals. The board approved the launch for procurement for community equipment services in Lancashire, and considered or was updated on progress made around the RCB's risk management framework and the work that the board had undertaken in May. The meeting on the 15th of June, as Steve's already referred to, focused on year-end governance matters, including the approval of the 25-26 annual report and accounts for submission to NHS England. Since that meeting, the RCB has had confirmation from NHS England that the submission was compliant. So this will now be published on the RCB's website, and it will be the basis for our annual general meeting, which will be held on the 17th of September.
Thank you very much, Deb. So, any other business? No, in which case, thank you very much indeed. Some good discussions, and I will look forward to seeing everybody at the next public board meeting on Thursday the 17th of September.